complications and how to prevent them, patients are going to have bad outcomes. The specific predictors of complication were age, the retrograde approach, and the height of the JCTO score, and we'll hear more about that here. And all deaths were associated with a perforation. So these are complications that are very, very relevant. I think, the current status of this is it's been published, there's sub-studies published as well, and I think in wrapping up this talk, what I will suggest is two things. One is this past year has had 2 randomized trials. I do think that the trials will generally show improvements in quality of life, but at the downside of this increase in complications compared to conventional PCI. As a result, if we're going to offer these therapies to our patients, it's on us to ensure that they're truly symptomatic, and it's on us to ensure that we genuinely know how to take care of these patients in the most safe and effective way to maximize their outcomes. Thanks so much.
Thank you, Dr. Ajay, for your excellent presentation. Because shortage of time, we move to next topic, that is Orbita-1 trial by Dr. Soumitra Kumar. Please, Dr. Soumitra.
Good afternoon, esteemed chairpersons, ladies and gentlemen. My trial is Orbita, and I have to explain 2 things with regard to this trial, as the caption says. Why I should congratulate the investigators, but again, in the same breath, I should explain why it should not change my practice. Now, whereas PCI in ACS is a resolved issue, PCI in stable ischemic heart disease continues to be a bone of contention for us. And the reasons are, we are still questioning ourselves what is the best initial management strategy for patients with SIHD, and what is the evidence that early revascularization improves prognosis. Now, you are all aware of these contemporary studies with regard to SIHD, Courage, Barry 2D, FAME 2 stitch, and the last one, that is ischemia, is still going on. Now, what has been irrefutably proven in these studies is that RCTs have not been able to demonstrate a survival benefit for fixing coronary stenosis in SIHD. And the reasons that have been put forward are that dissociation between the angiographic or physiologic severity of a stenosis and underlying atheroma and propensity to become a culprit lesion. Atherosclerosis is known to be a systemic and a progressive disease with diffuse coronary artery involvement, and intensive guideline-directed medical therapy and lifestyle intervention have changed the underlying biology and natural history of atherothrombotic disease. So the fundamental question that we continue to ask ourselves, if clinical trials in the OMT era show no clear death or MI benefit from an initial strategy of revascularization, do we need to CAT or revascularize patients prior to initiating an empiric trial of OMT? This is the trial I talked about, ischemia trial. It's still ongoing. A large trial, sample size 8,000, average follow-up 4 years. The groups are PCI or CABG plus OMT, whether it is superior to a conservative strategy of OMT alone, with CAT reserved for OMT failure. Composite primary endpoint is CV death or MI, and secondary endpoint is angina-related quality of life. But till the ischemia results are published, we are faced with a situation that over 5 lakh PCIs per year for stable angina is done globally. Size of angina relief beyond placebo is unknown. With unblinded, I emphasize on the word unblinded PCI, the advantage is 96 seconds gain in exercise time. With single drug therapy, in contrast, it is 55 seconds. So in this background, the Orbita investigators thought it would be prudent to look at only the quality of life. And in this regard, they thought that PCI arm should have a placebo control, because according to the protagonist of medical therapy, there is a placebo effect of PCI. So they wanted to prove whether PCI increases exercise time more than placebo procedure, the primary endpoint being difference in exercise time increment between the arms. So the sample size was calculated to be about 200 patients. The inclusion criteria, stable angina, one or more 70% stenosis in a single vessel, and they should be suitable for PCI angiographically. So the trial design was that there was an enrollment process, then medical optimization phase, then the pre-randomization assessment with regard to CCS score and the Seattle Angina Questionnaire with my previous speaker just alluded to. Then they had the blinded procedure. They had the angiogram, and they also had as a research protocol not only FFR but the new IFR, that is instantaneous wave-free ratio assessment also. Then the blinded procedure was carried out, either actual PCI or the placebo procedure. The follow-up assessment again included the same parameters, and both pre and randomization and follow-up included exercise test and stress echo assessment of wall motion abnormalities. The usual blinding procedures were done. Same medical therapy was given to both the arms. The placebo arm also treated as if PCI was done. There was no access to CAT report for patients and their parties, and they were given the same discharge letter. So this is the trial I'm designed in a nutshell. They started with 230 patients enrolled, ultimately 200 patients randomized, and then divided in the two groups, that is the actual PCI and the placebo procedure. The stenosis severity, FFR and IFR parameters, as you can see here, were absolutely comparable in the two arms. In terms of the primary endpoint result, the change in total exercise time, there was a marginal benefit in the PCI arm compared to the placebo of plus 16.6 seconds, which was not significant. But in terms of the stress echo results, in terms of peak stress wall motion index score, there was a significant reduction in the ischemia burden in the PCI group compared to the placebo group. And you can see the p-value was significant. In terms of the CCS class improvement, the two groups were comparable. So the conclusions of the Orbiter trial was that it is the first placebo-controlled randomization trial of PCI in stable angina. Patients had significant stenosis in terms of the quantitative assessment, FFR and IFR. PCI was safe and physiologically effective. It significantly reduced ischemia burden as assessed by stress echo. And in this single vessel angiographically guided trial, there was no difference in exercise time increment between PCI and placebo. So in context, it was a single vessel PCI for stable angina, guided by angiography. Focus was on symptomatic relief, and intensive medical therapy was given to both the PCI and the placebo-controlled arm. But there are some criticisms. Power of the study to detect a difference between the groups was lower than planned, perhaps as low as 20%. Comparing changes in a parameter such as exercise time is fraught with difficulty when the starting point in the two groups are different. Mean exercise time was 30 seconds higher at baseline than in the PCI group. Population was low risk. Everyone had single vessel disease. The dobutamine stress echo wall motion score was only 1.1 at baseline, and mean exercise time was 8 minutes and 48 seconds at the baseline in both the groups. PCI was able to normalize in-lab physiology assessed by FFR, IFR. It significantly reduced ischemia burden by stress echo and even increased exercise duration compared to baseline by 28.4 seconds. But remember, the patient's population chosen was little elderly, so within the short-term follow-up of 6 weeks, it is not easy to get an average 65 years old's exercise duration up further when it starts at that level of 8 minutes 48 seconds. So just like the OMT used in Courage trial, the real-life scenario is that who does have the time and patience to call patients 3 times per week outside the RCT scenario to assess their response to intensive medical therapy. This is not a real-world proposition. So Orbiter was a trial which was designed to succeed. Beauty of its design is not that it mirrors real-life practice, but it internalizes the clinical uncertainties that cardiologists face. Duration of run-in and follow-up gives an idea of duration in which medical therapy should be encouraged and actively pursued. It also suggests that in patients with an exercise time greater than 8 minutes, medical therapy should be pursued with the greatest vigor. So I thought that I should propose this line of management till ischemia results are published. If you have a patient of stable angina, cardiac CT should be done to exclude LMCA disease or LMCA equivalent, as is also being done in the ischemia trial. Give OMT for a short burst. If symptoms improve and patient is satisfied, continue OMT. If symptoms don't improve, go for exercise stress test. If exercise time is more than 8 minutes, continue OMT. If it is less than 6 minutes, FFR-guided PCI should be done. So my reaction to Orbita, keep on stenting judiciously in stable ischemic heart disease. So to conclude, ladies and gentlemen, whether PCI is indicated for better outcome in stable patients with CAD, independent of symptoms, could not have nor was it intended to be addressed in Orbita. This will require a much larger RCT using state-of-the-art technology such as ongoing ischemia trial. But a rider from this Orbita trial that 4 patients in the placebo group had pressure wear related problems. Whether it was accidental or operator inexperience is not known to us, but this will lead to more use of non-invasive FFR with CT or MRI at the same time when the first assessment is done is to be a more accessible alternative. Thank you very much for your patient hearing.
Thank you, Dr. Kumar. Now we invite Dr. Sarat Chandra for the next topic. How does it change our practice of PCI in a patient of atrial fibrillation on oral anticoagulants?
Thank you. These 2 trials, Pioneer AF, which came in 16, and Redual PCI that came in 17, have shed a certain light on the treatment of patients of atrial fibrillation or those who are receiving oral anticoagulants in the long term for a variety of indications. If they undergo PCI, how do you manage their oral dual antiplatelet therapy? Look at this patient, a classical case of a 65-year-old lady who presented with acute coronary syndrome with ST depression in inferior lateral leads, positive troponin. Creatinine was 1.8, which boils down to a eGFR of about 60 to 70 ml, given her body weight, and cath lab is available, and she's a known case of atrial fibrillation. She has a CHADS-2 vascular score of 4, currently taking dabigatran 150 milligram twice daily for atrial fibrillation, and the last tablet she has taken was 8 hours ago. Now, in this kind of patient, there's likely to be confusion. How do you manage this case? Now, what is the prevalence of this problem? Up to 30% of atrial fibrillation patients who are on vitamin K antagonists have coronary artery disease and are potential candidates to receive DAPT in the near future. Between 5 to 10% of patients undergoing stent implantation necessitate oral anticoagulation in the long term for a variety of reasons. So if that is the case, what is the issue? The issue here is you need to combine in these patients vitamin K antagonists along with dual antiplatelet therapy if they undergo PCI and receive a stent or 2. This combination is good because it reduces the risk of thrombotic events, but it markedly increases the bleeding risk up to 3 to 5 fold because of the presence of all 3 agents, which is popularly called triple therapy. One of the first trials to look at the outcomes in this kind of scenario is the VOYAGE trial. It is published way back in 2013. What have they done? They have taken one arm which was given triple therapy in the standard fashion of aspirin plus clopidogrel plus vitamin K antagonist, and in the other arm they just gave oral anticoagulation along with once daily clopidogrel. It was given for 1 month minimum after BMS and 1 year minimum after DES. They looked at this because they hoped that by excluding aspirin, the bleeding complications would come down without an increase in the stent thrombosis. Now, what are the results? The dual therapy and triple therapy more or less are matching in their baseline characters. Atrial fibrillation was the predominant indication in nearly 70% of the patients. A mechanical valve was present in about 10% and other indications in about 20%. Acute coronary syndrome was the indication for PCI in about 25 to 30% in both the arms. Now, the results show that the mortality, myocardial infarction, target vessel revascularization, stroke of any kind, and stent thrombosis, they are all more or less same in both the arms. Particularly important is to note that the stent thrombosis incidence has not increased with dual therapy of vitamin K antagonist plus clopidogrel. It is expected that by excluding aspirin, the chances of stent thrombosis may increase, but it has not happened, indicating that probably vitamin K antagonist given in proper dose along with clopidogrel is enough to prevent stent thrombosis. But what happened to the bleeding complications? You can see here on the top, there was a 44.4% incidence of bleeding complication with triple therapy, and in dual therapy, it is just 19.4%, indicating that triple therapy markedly increases the risk of bleeding complications. Now, the new P2Y12 inhibitors naturally have come into the picture because we know that the so-called NOVAX, whether it is dabigatran or rivaroxaban, are associated with lesser bleeding complications compared to vitamin K antagonists. These drugs do not require close monitoring. There is no need of repeated testing. And most importantly, the intracranial bleeds are considerably less in the case of NOVAX. The first trial in this regard was Pioneer AF PCI trial. Here they have tried 3 arms. One is, of course, the standard vitamin K antagonist plus dual antiplatelet therapy, the so-called triple therapy in one arm. And in the other 2 arms, rivaroxaban was tried in differing doses. One arm had 10 or 15 milligrams of rivaroxaban along with clopidogrel. It is like the OS2 trials test arm. And the other group is rivaroxaban 2.5 BD plus DAPT for 1 month, followed by 15 or 10 milligrams of rivaroxaban along with aspirin once daily. That is like the Atlas group. What did the results show? The results show that Pioneer AF PCI showed similar rates of thromboembolic events across treatment groups with low power to demonstrate efficacy. The MACE rates were same in all the 3 groups, and stent thrombosis also has not increased in those 2 groups of rivaroxaban where aspirin was excluded. What happened to the bleeding complications? You can see here that compared to vitamin K antagonist plus DAPT, rivaroxaban plus DAPT had significantly less bleeding complications, and even the other arm also had 16.8%. And you can see in this slide that both the arms of rivaroxaban have got significantly lower bleeding complications compared to the triple therapy. And after this, Dr. Deepak Bhatt has written an editorial saying that this is probably the beginning of the end of full-dose triple therapy with warfarin. Immediately or very soon came the redual PCI, which was presented in European Society of Cardiology meeting last year. And this one has tried dabigatran, 150 milligram dose as well as 110 milligram dose, along with clopidogrel. And of course, the third arm was the standard triple therapy. And let us look at the results. You can see here that there is significantly lower rates of ISTH major bleeding with dabigatran dual therapy. Both 110 and 150 had lower incidence of bleeding complications, slightly higher with 150 milligram dose. And you can see here that TB major and minor bleeding also were significantly lower with dabigatran dual therapy. Intracranial hemorrhage obviously is significantly less with dabigatran in both the arms compared to the warfarin, and the dual therapy with dabigatran was non-inferior to warfarin triple therapy in terms of efficacy. So when you use the NOVAX along with just clopidogrel, you have equally efficacious regimen without the incidence of increased bleeding complications. So this particular patient, in view of her slight renal insufficiency, was discharged home on rivaroxaban 15 milligrams a day with Plavix 75 milligrams a day. Only on the first day, she received aspirin 325 milligram. The conclusion from both these trials and the OS2 trial is that you can get away by using the NOVAX with just clopidogrel once a day. Of course, into this group, the prasugrel and ticagrelor do not come because there is one trial done from Munich where they tried prasugrel along with the Novax, and they found that the bleeding complications were considerably higher. So if you are going to use oral anticoagulation, the P2Y12 inhibitor of choice is simple old clopidogrel, and probably that's the way to go. Thank you.
Thank you, Dr. Sarachandra. We now invite the next speaker, Dr. Iyengar. He will be speaking about Fourier trial.
Good evening, Chairman, ladies and gentlemen. I would like to dedicate this presentation of mine to Air Chief Latif, who was an adorable chief and a great human being from this great city of Hyderabad. I will be discussing the Fourier trial where PCSK9 inhibitor evolocumab was used and what is its impact on the lipid targets in future. Atherosclerotic cardiovascular disease, there is an alarming increase in prevalence and incidence. Prevention holds the key for success in this battle against atherosclerotic cardiovascular disease. Dyslipidemia is one of the major modifiable risk factors, and when treating dyslipidemia, the focus is on LDL target. And while reducing LDL cholesterol, we have already therapeutic lifestyle changes, statins and ezetimibe on board, and now PCSK9 inhibitors are knocking on the door. What is this PCSK9? This is a pro-protein convertase subtilisin klexin type 9. This degrades the LDL receptors, so the LDL cholesterol goes up. So if you give PCSK9 inhibitors, it will reduce the degradation of LDL receptors, the LDL cholesterol will come down, and in this study, Fourier, evolocumab was used, which is a fully humanized monoclonal antibody. Bioavailability is 72%, and half-life is 11 to 17 days. In this Fourier trial, 27,000 patients, high-risk, stable patients with established cardiovascular disease were studied. They did not reach the LDL cholesterol of less than 70. Then they were randomized to evolocumab versus placebo. And at the end of 2.2 years, the LDL cholesterol came down from 92 milligram to 30 milligram. So evolocumab over and above statin not only brought down the LDL cholesterol by 59%, it also reduced non-HDL cholesterol by 51%, ApoB 46%, LPA by 27%, triglyceride by 16%, and HDL cholesterol increased by 8%. And this reduction in LDL translated into significant reduction in the risk of primary endpoints of cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization, and this was by absolute 2% points and statistically highly significant. It also reduced the secondary endpoints, again by 2% absolute, cardiovascular death, MI, and stroke. The reduction in LDL cholesterol takes some time, but it grows in time. As you see in this, in the first year, there was 16% risk reduction, whereas in the second following year, there was 25% risk reduction in the key secondary endpoints, as well as fatal, non-fatal, MI, and stroke. So lower is better, and this benefit accrues down to the level of 20 milligrams of LDL cholesterol. So with this low LDL we are achieving, are there any concerns about the safety? The study shows there is no concern because there is no difference between the two groups as far as adverse events are concerned, except probably the injection site reaction with evolocumab. And other point which all of us are concerned is the neurocognitive events. There is no difference between the two. And even those subjects where the LDL cholesterol was less than 20 milligram, there is no difference between the two groups as it came to neurocognition, liver enzymes, muscle enzymes, non-cardiovascular death, or hemorrhagic stroke. So evolocumab, when you give on background of statin therapy, lowered LDL cholesterol in this study to a median of 30 milligram per deciliter and reduced the risk of cardiovascular events. These findings show that patients with atherosclerotic cardiovascular disease benefit from lowering of LDL cholesterol levels below current recommended targets. This is also supported by some sub-studies of Fourier. When you looked at the diabetic population, it effectively reduced the LDL cholesterol in this diabetic population and reduced the risk of endpoints. It also looked at the patients with peripheral arterial disease who have a high risk of cardiac events. This PCSK9 inhibition with evolocumab significantly reduced that risk with large absolute risk reductions. Moreover, lowering of LDL cholesterol with evolocumab also reduced risk of major adverse limb events. Then this Ebbinghaus study looked at the so-called neurocognition in a more objective manner by using the Cambridge neuropsychological test, and they found that no clinically relevant or statistically significant changes were observed with the addition of evolocumab to statin therapy. So again, these findings lean strongly towards supporting the safety of lowering LDL cholesterol below the current recommended targets. They also looked at certain subgroups which are going to probably derive additional benefit by using evolocumab, and they found that those patients who had recent myocardial infarction, those patients who had multiple myocardial infarction in the past, and those patients who have multivessel disease will derive more benefit with use of PCSK9 inhibitors. The Glegoff study, which looked at 970 patients with IVERS at baseline and after 78 weeks of evolocumab, found that there is significant reduction in total atheroma volume in the group of statin evolocumab group as compared to the statin monotherapy. Also, nearly 81% of them patients showed regression as compared to only 48% patients who are on statin monotherapy. So we have come a long way. Initially, we thought high cholesterol is bad. Later on, we learned that even average LDL cholesterol is not good. Then, with TNT and ProVitimi study, we learned that lower is better. And with Improved study, we know that even lower is even better. With this Fourier study, we now know that lowest is the best. So, but PCSK9 inhibitors are pricey. They are quite expensive. So do we have certain group of patients who are going to benefit much more? So they try to identify what is called the highest risk, highest benefit group. So we should adopt this strategy of highest risk, highest benefit group. The patients who are going to benefit most are patients with atherosclerotic vascular disease plus diabetes, patients with ASCVD plus CKD, patients with recent acute coronary syndromes, patients with uncontrolled risk factors, patients with peripheral arterial diseases, CHD with patients more than 65 years, stroke patients, and coronary heart disease patients, and familial hypercholesterolemia. So we have these guidelines, particularly from the Western cardiology societies. The LDL target has been set as less than 70 mg/% for very high risk. But Lipid Association of India, for the first time in 2016, came with the guideline that LDL cholesterol should be less than 50 mg in very high-risk patients. Then followed the AACE guidelines, ADA guidelines, and Taiwan, the Cardiology Society guideline, which all say that LDL target should be less than 50. So with these studies in background, probably the future lipid targets in group of patients who are at highest risk and who are going to benefit should be less than 50, and you can come down to up to 25. So in conclusion, Chairman, ladies and gentlemen, PCSK9 inhibitors are knocking on the door. They are welcome to the present armory. Target of LDL cholesterol in high risk, high benefit group, still lower, is still better, and is quite safe. Thank you.
Thank you, Dr. Iyengar. We now move to the last presentation by Dr. Prasad on multi-vessel PCI versus CABG.
Thank you, Mr. Chairman. My job is to, in a very short period of time, as the last speaker of the day, try and keep the attention of everybody here to try to see what trumps multivessel PCI or CABG in patients with multivessel CAD. So a quick background. This topic's been obviously debated for many years with every advancement in PCI, starting from POBA to bare metal stents to now second generation, third generation drug-eluting stents. CABG has always trumped PCI in multivessel disease. And this difference continues to be substantial in patients with diabetes in spite of sort of an improved performance of drug-eluting stents in most other subgroups. And most of these differences have been largely driven by differences in TLR and largely due to the protective effect of the left internal mammary artery. So the objectives of my talk is to review data that's relatively new from 2018, understand what the shortcomings might be of the data, focus on why PCI has fallen short, and then provide a framework for a management algorithm that I think makes sense, and then end with a case example. So a quick clinical vignette to just sort of get the talk going. There's an 80-year-old guy, he's got an ACS, his strokes are positive, he's got the usual risk factors, his creatinine is 1.7, he has mild LV dysfunction, he's had a remote PCI to his diag, he's got peripheral vascular disease, he's smoked in the past, his STS score is 6, and he has moderate COPD. These are his baseline angiograms. So as you can see, he's got clearly multivessel disease. He's got disease in the left main extending into the LAD. He's got a lesion in the ramus or high OM. He's got a high-grade lesion in his right coronary. Let's focus back and look at some data that was most recently published last month in the Lancet that looked at patient-level meta-analysis from 11 PCI and CABG studies enrolling more than 11,500 patients. In this study, you can see that patients who had PCI and had multivessel disease had a higher mortality up to 5 years. And that mortality difference was statistically significant. It was a hazard ratio of 1.2 with a fairly tight confidence interval. They also looked at stroke. And similarly, patients in the same subgroup who had underwent CABG had a significantly higher incidence of stroke in that same time frame. If you break it down into those patients who had diabetes and to those that didn't, you can see that the difference is a little bit more glaring in patients with diabetes, regardless of whether it being type 1 or type 2, with a difference of 15.7 and 10.7, with an absolute difference of roughly 5%. Whereas those that just had multivessel disease without diabetes, there was really no difference. As you can see, the difference was 8.7 versus 8.4, which was statistically not significant. Interestingly, patients with left main disease in this same meta-analysis, which was also looked at, did not have any difference. So why do we believe that we've fallen short with PCI? Well, I think there are several things. The first thing that comes to mind is, have you really been able to achieve complete revascularization with PCI as compared to CABG? And that's the question we need to ask ourselves. The second is, have you really been able to treat the most common reason why we can't achieve complete revascularization, i.e. a CTO, successfully in a reliable fashion with a low complication rate? Number three, have we employed contemporary PCI technique? Have we used adjunctive imaging? Have we used functional PCI? Or have we just used angiography to determine who gets stented and who doesn't? We do know for a fact, based on data, that everolimus-eluting stents are clearly better than paclitaxel-eluting stents. And that was elegantly demonstrated by Dr. Call with the Tuxedo study in diabetics that was published in the New England Journal, as well as previous data that we clearly demonstrate based on the SPIRIT 1, 2, and 3 data that Dean Kyriakis has presented and is published since. And the last question is, what happens when the surgeon says no? And that's real life, right? I mean, a lot of the times we end up in a situation where we have surgical turn-down patients that also need to be treated. That takes me to a study that is going to look at this in a little bit more detail. And that study is called the Optimum Study. That is, has commenced, and we're in the study enrolling patients to try to look and answer this very question. Ajay, who's here, is part of the steering committee of this study, and the national co-PIs are Aaron Grantham, Dave Kanzari, and Adam Salisbury, housed in Mid-America Heart Institute in St. Louis. So what the study is going to look at is, with a core lab adjudicated manner, the completeness of revascularization, and then follow these patients at 1, 6, and 12 months, and these are patients that have been surgically turned down. They will either be treated with guideline-directed medical therapy or will have index or staged PCI as deemed appropriate. And then we're going to be looking at 1-year MACE and 5-year mortality. What this is going to tell us is describe anticipated risks, benefits, and give us answers about what happens to patients who are deemed high risk and have been turned down for surgery that now come back into our court in the cath lab. This is a type of form that the surgeon has to fill out when he signs up to participate in this study. It's not part of the patient chart, but he has to provide a primary reason why he thinks this patient is not eligible for surgery, and then enlist all other supporting criteria that he may have that might add to that, namely poor targets, poor age, lung disease, frailty, immobility, prior stroke, infection, pulmonary hypertension, obesity, et cetera, et cetera, et cetera. And then the last thing is, there is a comment at the bottom that looks at what the surgeon's personal assessment of his STS score is, rather than just looking at the STS score as we know it. Let's talk about this business of complete versus incomplete revasc. We'll look at syntax first, and as you can clearly see, if you have incomplete revasc and you have a residual syntax score greater than 8, as shown in the green panel, you have an estimated event rate and a MACE rate of almost 60%. You compare that to a patient who has a low syntax score of almost 0 at the end of his procedure, and his 5-year MACE rate is almost half that. Similarly, all-cause death in the patient that has the highest syntax score is almost 4 times higher than somebody whose syntax score is 0 or 0 to 4. This is a more contemporary study that was published in Circ that looked at the outcomes, both acute and long-term, in patients with multivessel disease with complete and incomplete revasc with contemporary drug-eluting stents, all done angiographically, and once again, clearly demonstrating that MACE-free survival up to even 5 years is significantly better in patients who have complete revascularization. And then the real question is the residual syntax score predictive of functionally complete revascularization? And the answer is yes, because if you eliminate the incompleteness of revascularization, you find that the residual syntax score is no longer predictive of long-term outcomes. This is the FUI experience, which is the largest study that is a single-center Chinese study that looked at almost 12,000 patients, and again divided them into 3 categories: those that had complete revascularization, those that had relatively incomplete revascularization, and those that had incomplete revascularization. And once again, you can see that the baseline syntax scores at the bottom in the red panel have a clear gradation, 9 being that for patients who had complete revascularization, 12 being those that had relatively incomplete revascularization, and 21 that had incomplete revascularization. Once again, in a more complex, more triple vessel disease with CTOs is where we fare the poorest with PCI, because we are unable to provide them with the same degree of benefit that a surgeon can. This is, again, looking at this with the syntax score in the y-axis and the baseline syntax score on the left, clearly demonstrating that the higher the baseline syntax score, the higher the residual syntax score, hence poorer the outcomes. Again, all kinds of outcomes, death, myocardial infarction, revascularization, are all significantly worse in patients that have a high residual syntax score. So how can we optimize our PCI results? Well, we need to first deal with the technical limitations in dealing with complex disease. There needs to have operator expertise to achieve complete revascularization, and sometimes that means having a retrograde skill set. We got to do better than use adjunctive imaging less than 20% of the time. And plus, we need to be able to act on the information we have from the adjunctive imaging, i.e. have competencies in the use of atherectomy, both orbital and rotational, and use laser. And the last but not the least is we need to do a better job with secondary prevention and guideline therapy post-PCI. This is clear evidence across the board in all the different lesion subsets that we would consider high risk. Long lesions, bifurcations, osteals, left mains, where there's clear evidence that use of intravascular ultrasound provides mortality benefit and reduces MACE, and yet worldwide the use of IVUS is less than 10%. What about management strategies that I would recommend in patients with multivessel disease today? I would suggest that patients with multivessel disease, if they're clinically eligible for either CABG or PCI, should possibly be considered for CABG, especially if they have left main disease in addition to complex multivessel disease. If they have multivessel disease with diabetes, once again, CABG is probably on the table, or at least in the discussion. If you don't have diabetes, then there's clearly an opportunity to assess patient preference, have something we call shared decision-making, look at factors that we would consider favorable factors for PCI, i.e. patients who have potentially a high stroke risk with CABG, patients who potentially would not recover well after a long operation like bypass surgery, and at a high risk for AFib, bleeding, and wound complications with a sternotomy. We're going to look at this more carefully in the FAME-3 study, which is going to look at all comers with three-vessel coronary disease, excluding left main disease, where a heart team identifies patients that are randomized to PCI or CABG, and then perform FFR-guided PCI with a contemporary drug-eluting stent, or CABG, and then the primary endpoint being 1-year death, stroke, myocardial infarction, and revasc. And it's being powered for non-inferiority, with a key secondary endpoint that will look at 3-year death, MI, and stroke. So going back to our last case, so here's this guy, his syntax score was almost 40, but he was 80 years old. Our surgeons turned him down. So his angiogram, as you remember, was fairly complex. So we optimized his right coronary with orbital atherectomy and intravascular ultrasound and implanted 4mm drug-eluting stents all the way from the crux up to the right coronary and post-dilated them approximately with a 5.0 after intravascular ultrasound demonstrated that to be the size of the vessel. Then attacked the left main, and once again was able to perform orbital atherectomy, intravascular ultrasound, drug-eluting stent employment of the left main into the LAD. After a suitable part of the LAD using dedicated catheters like a Supercross and Twin Pass, was able to get into that first and second OM and treat the bifurcation appropriately with a DK crush and end up with a result that looks like this. So in conclusions, I would suggest that CABG with PCI for multivessel disease is not a single answer, it's a nuanced topic, and is not a question that can be answered by a single randomized controlled trial or even a single meta-analysis. And the reasons for that is threefold. The event rates for hard endpoints are low. Technology sort of is